Hi, this is Professor Widener. We're going to continue with Chapter 9, gastrointestinal function. We're going to pick up with disorders of the liver, starting with hepatitis. Hepatitis is an inflammation of the liver that is caused by infections, alcohol, medications, or autoimmune diseases. It may be acute, chronic, or fulminant. Sometimes it is viral, sometimes it's non-viral. There are 5 different kinds of hepatitis, but we are going to be focusing on the ones that are most common in the United States, which are hepatitis A, B, and C. If you look at table 9.3 on page 416, you can see it gives you a little bit about the information. It gives you a concise breakdown of the information for type A, type B, and type C. And I'm going to let you read through those. But the other important table, and I'm telling you, this comes up on all exams. It'll come up on my exam and it comes up on certification exams. Table 9.4, which is the viral hepatitis profile. They will give you different hepatitises with the antibodies, the total antibodies. So make sure you take a look at that table and commit that to memory, because believe me, it comes up all the time. There are 4 phases of acute hepatitis. At first, there is an asymptomatic intubation period. And then about 2 weeks after exposure or infection, there is a prodromal phase. This is where you start with some viral type symptoms like nausea, vomiting, headaches, aches and pains. And then after about another 1 to 2 weeks, you develop the iteric phase, which is where the person may develop jaundice, tea-colored urine, pruritus, or right upper quadrant pain, or hepatomegaly. The next and final phase is recovery, which generally happens 6 to 8 weeks after initial infection and is signified complete when all the jaundice is resolved. As far as the clinical manifestations, it really depends on the kind of hepatitis that it is. And you will note that some have rashes and arthralgias as extrahepatic manifestations. The serum hepatitis profile for diagnosis, again, that's on page 417. Treatment really prevails around prevention. So at this point, all children born in the United States are vaccinated with hepatitis B. If you were born before, I think they changed that in 2010. If you're born before 2010, it was not required for everyone to have it. But if you're a healthcare worker, you have probably had hepatitis B vaccines. Hepatitis A is something that is not especially as common, but there is a vaccine for that as well. Treatment revolves, really, it depends on the extent of the liver damage and other circumstances. Interferon injections and antiviral medications can help. There's also a need for lifestyle modifications. For example, if someone is an alcoholic or they're injecting drugs, those would be some of those modifications. The other thing, as far as transmission counseling, it can be type B and C can be peritoneal and venereal through blood or contact. So you need to take precautions to prevent that transmission. And if it gets to be too bad, considerations for liver transplant need to be made. Cirrhosis is damage to the liver resulting in decreased liver function. It is chronic, progressive, irreversible, and diffuse. It can be caused mostly, it is caused by a hepatitis C infection or chronic alcohol abuse. There is non-alcoholic fatty liver disease is becoming an increasing reason for cirrhosis due to the increasing obesity rates. Cirrhosis often starts with nonspecific manifestations where people have anorexia, fatigue, weight loss. They may even have some jaundice. The manifestations of cirrhosis progression include portal hypertension. And that's where you may see, you'll start to see the development of ascites and poor nutritional absorption. So although they'll have a lot of fluid around their stomach, they will look malnourished. As the bile accumulates, the kidney function declines. The key to this is diagnosis, and diagnosis can be done via abdominal ultrasound, liver biopsy, liver enzyme panels, endoscopy, or non-invasive markers for fibrosis. Treatment is really aimed at slowing and preserving liver disease. So the first thing, early diagnosis is, again, the treatment. You can slow it down, but it is a progressive disease, and I've seen some severe cases. It's quite sad. You want to prevent and treat the complications and manage any clinical manifestations. Some of the complications as this gets further down the road, if you look at page 420, you'll start to, there's a good diagram of the effects of hepatic failure and portal hypertension. But some of the complications include varices, which are thickened blood vessels in the esophagus that can present a problem. Ascites, which is, excessive fluid around the abdomen. Spontaneous bacterial peritonitis. So that's something you want to think of if someone comes to the office with a history of cirrhosis and severe abdominal pain. Hepatorenal syndrome is where the liver and the kidneys just basically shut down and are stop working. It's very difficult to stop and reverse. People can have pulmonary complications such as shortness of breath. They can get secondary fluid backup, and hepatic encephalopathy, which is where the ammonia backs up because the liver can't clear it, and people have change in mental status. So I'm sure you've all seen these patients in the hospital. Our job as primary care providers is really to prevent, encourage whatever has caused this to stop and slow the progression. People can be liver transplant candidates. It kind of depends on the situation. If, for instance, though, someone is an alcoholic, they must refrain from alcohol use for 6 months prior to being put on the liver transplant list. And to be on the list, you must also be cancer-free. So they'll also do a complete cancer workup on you to make sure that you don't have it, because cirrhosis can lead down the road to liver cancer. Moving along, we're going to talk about pancreatitis, which is inflammation of the pancreas. Causes, we always typically think about the first cause as being alcohol abuse. There can be other causes, but that's probably the most common. Some of the other causes include cholelithiasis or gallstones, trauma, renal disorders, hepatotoxic drugs, and medications. I actually once had a patient who came in with pancreatitis. We could not figure out what was the cause of her pancreatitis, and it ended up being a random medicine. I can't remember what it was at this point, but pancreatitis was not even on the list of possible complications for this medicine, but that's actually what it was. So sometimes you have to think outside the box to actually get the diagnosis. And when we're talking about medicines, remember a lot of the new diabetic medicines are directly affecting the pancreas, and one of the possible side effects is pancreatitis. Acute pancreatitis is a medical emergency, and we will talk about that a little bit more. And chronic pancreatitis often leads to the development of diabetes. Symptoms for acute pancreatitis include epigastric and mid-abdominal pain, nausea and vomiting, jaundice, fever, blood pressure, and pulse changes. These patients often look very sick when they come to see you. They cannot eat any food. And you'll make the diagnosis by history and physical exam, serum amylase and lipase levels, which are the pancreatic enzymes, will be elevated. You also want to check a CBC and to check for signs and symptoms of infection, and a BMP to check for signs and symptoms of dehydration. You may also want to do some imaging studies to determine, if you don't know the cause of the pancreatitis, to see next, like if there is a gallstone or something else going on with there. Initial treatment for acute pancreatitis is done in a hospital. It needs to be with dietary and fluid management and controlling the nausea and vomiting with pharmacological agents, the pain and the infection. Pancreatitis can turn very badly very quickly. So these folks need to be hospitalized. If you get someone that you're suspicious in the office for pancreatitis, you need to send them over to the hospital. I have seen, I once had he was 24, and he came in with basic pancreatitis from alcohol abuse. But over the course of 3 days, he continued to deteriorate, and to the point where he developed hepatorenal syndrome. And we actually had to life flight him to a local hospital because I work in a small rural hospital. And he was on dialysis, and actually he did okay. He got better, and he came home like 2 weeks later, but he progressed very rapidly. So although these patients don't seem as sick, or you're not doing a whole lot for them, close monitoring of them is super important because it can turn bad pretty quickly. Next, we're going to talk about disorders of the lower GI tract. We're going to start with diarrhea. This is a change in the bowel pattern that can be characterized by increase in stool frequency, amount, and content. Gastroenteritis is often seen as acute onset of diarrhea, nausea, or vomiting. This can be caused after something like food poisoning. Manifestations depend on the cause of it, and the origin. It often depends on whether it's from the small or large intestine. If it's from the small intestine, stool tends to be in large quantities, loose, and provoked by eating. If stool originates from the large intestine, it tends to be smaller stools and more frequent. Diarrhea is often diagnosed by history and physical exam. Again, you want to ask about their recent travel history, because there are some diarrheal causes that can come from traveling. You also want to talk if they've been on antibiotics anytime recently. Treatment revolves around maintaining hydration and correcting imbalances. It's usually a short term and can be made better with pharmacological agents. The one thing I will caution you on is that you should never give someone Imodium until you are 100% sure of the cause of their diarrhea. Because if you give someone Imodium who actually has an infectious diarrhea or C. diff or something like that, it could really be detrimental to them, because what the diarrhea is doing is trying to clear the infection. So please be very cautious with using Imodium. It's not as light of an issue as you think it might be. Constipation is caused by bowel pattern changes characterized by infrequent stool. Causes can be narcotics, decreased ambulation, surgery, and aging. There is sometimes pain during bowel movements or inability to pass stool. Some of the complications can include bowel perforation. It's very important, again, to make sure that people are moving their bowels. The one thing that I will tell you is that some people will not move their bowels every day, and that's okay. Whenever you're asking someone about their bowel pattern, you want to know, again, is it normal for them? We may expect them to have a bowel movement every day, but they may tell you that they've only had a bowel movement every other day for the last 50 years. Well, that's normal for them. So again, just as a word of caution, when we're asking about changes in patterns and things, remember, it may be normal for that person because not everyone is the same. Diagnosis can be made by abdominal X-ray, upper GIs, a barium swallow, a colonoscopy, or a proctosigmoidoscopy, which is basically a short colonoscopy. Treatment can include increasing dietary fiber, avoiding constipating foods, increasing activity, defecating when the urge is sensed, taking some stool softeners, but limit the use of laxative and enemas. And should the pain be so severe, digitally removing the impaction may be necessary. An intestinal obstruction is a medical emergency. This is when the intestinal content is blocked either in the large or small intestine. This can either be a mechanical cause or a functional cause. It is often sudden. People may have a partial obstruction or a complete obstruction. These folks are in a lot of pain. And they often have abdominal cramping and colicky pain, nausea, and vomiting. They may not have any flatus. They may be constipated. Again, history can be made by can be made by history and physical exam, blood chemistries, and CBC. Often you will obtain an abdominal and pelvic CAT scan, and X-ray can be your fastest diagnosis if someone has an acute rigid abdomen. If you can see free air on a abdominal flat plate, that's cheaper and faster than a CAT scan. That they obviously need to go right to the emergency room. You wouldn't have to wait for a CAT scan. Treatment revolves restoring the imbalances and allowing the patient to have bowel movements again and bowel decompression. This can happen via NG tubes. Sometimes it's bowel arrest. Sometimes they need surgery. It just really depends on the cause and the severity. Our old friend appendicitis, again, common in folks 10 to 19, but anyone can have it. It is the inflammation of the variform appendix. It occurs usually as a result of the obstruction. The obstruction causes edema around the appendix, and it basically obstructs the appendix, so it needs to be removed. There's pain near the umbilicus as the first symptom, and pain and gradually intensifies. It does not usually come on suddenly. Classic manifestations include anorexia, nausea, or vomiting. Diagnosis is made by history and physical, CBC, an abdominal CAT scan, MRI, and ultrasound. I'm going to alert you because, again, of my own history. I had my appendix out when I was 32 years old, and I had abdominal pain off and on for a couple months, and they would keep telling me that my abdominal CAT scan was normal. Finally, I had a doctor at Thomas Jefferson, where I was working at the time, who, if you would have just physically examined me like we did in the old days, and I had a positive appendix sign, I would have just been taken to the OR and had my appendix removed. Interestingly, with the normal CAT scan, I found out that the trauma surgeon told me 25% of CAT scans are going to be normal when someone has appendicitis. So just an example that, please, these tools are there to help us, but they are not there to take away for our clinical judgment. After suffering with this abdominal pain that I thought was appendicitis, and of course got better when they gave me antibiotics and then it would come right back, I had surgery, and the pain was all gone because I had a very bad appendicitis. And in fact, it was full of pus and everything when they took it out. But anyway, surgery is the definitive treatment. And the point being, please listen to your patients. And all these tools are just part of the thing that help you diagnose things, but they do not take away your clinical judgment. Even if you only know as a beginning nurse practitioner, you know something is not right. You don't know exactly what it is, but something is not right. You can figure it out by doing these things to help you figure it out. So anyway, peritonitis is inflammation of the peritoneum. Remember, that's that protective coating that is in the abdomen. It can be caused by chemical irritation or direct organism invasion. The classic manifestation is abdominal rigidity. So when you feel that abdomen, it is hard as a rock. And this is a medical emergency. You're going to determine this by history and physical exam, a CBC, and probably a CAT scan if you have time. Some docs, I will tell you, will take people right to the OR based on that diagnosis alone of the rigid abdomen. Treatment includes surgical repair. They may need long-term antibiotic therapy and analgesics, but surgery definitely is going to be taking place. Celiac disease is an inherited autoimmune disorder, which is malabsorption of the small intestine. It results from a combination of immune response to environmental factors and genetic predisposition. It can result in nutritional deficits, and the symptoms vary and are typical to all of the GI disorder manifestations. History is done. Diagnosis is made by a history and physical exam, a celiac blood panel, and an EGD with biopsy. Treatment includes elimination of gluten and monitoring closely for cancer development, as it can predispose you to stomach cancer. Inflammatory bowel disease includes chronic inflammation of the GI tract, and that includes Crohn's disease and ulcerative colitis. These are immune responses that cause alterations in the epithelial barrier and immune cells, and they also have abnormal secretion of immune-related mediators. Crohn's disease is when there's patchy areas of inflammation that involve full thickness of the intestinal wall and ulcerations. Clinical manifestations include intestinal and extraintestinal manifestations. This is often diagnosed via stool sample, CBC, blood chemistry is a C-reactive protein, and imaging study. Frequently, when they're not having a flare-up, these folks will also have a colonoscopy for dietary confirmation. Treatment is dietary and pharmacological management. Ulcerative colitis is a progressive condition of the rectum and colon mucosa. It signifies epithelial loss, surface erosion, and ulceration from inflammation. Clinical manifestations include things that we have talked about before with GI disorders, and diagnosis is the same as it is for Crohn's. The key treatment really being biopsy to determine the final diagnosis. Irritable bowel syndrome is a chronic function GI condition characterized by exacerbations. So these folks often get periods of abdominal distension, fullness, flatus, frequent or constant diarrhea, and food intolerance. It's often exacerbated by stress. Their bowel patterns are altered and they have abdominal pain, but there's no real structural or biochemical abnormalities. Diagnosis is made by clinical presentation and a diagnosis of exclusion. So what that means is that we've excluded all the other diseases that it possibly could be, and we're left with irritable bowel syndrome. It's also based on history. There are dietary modifications and pharmacological strategies for treatment. Diverticular disease is related to the developing of diverticula. That's an outpouching of the intestinal walls. Diverticulosis is when someone has the outpouchings. Diverticulitis is when there's actually an infection of those outpouchings. Clinical manifestations include abdominal tenderness, specifically in the left lower quadrant. If you have someone who complains of pain in the left lower quadrant, diverticular disease is always your first thought. They often have a low-grade fever, constipation, and abdominal distension. For acute diverticular disease, I would do an abdominal CAT scan and check a CBC. Frequent, usually patients are treated with IV antibiotics. If someone comes in and they have a mild case, you could try to possibly use antibiotics as an outpatient, like Augmentin, something really broad spectrum, but you would need to keep a very close eye on them, like see them in the next day or two, or at least talk to them, because if for some reason their pain gets worse, they will probably need IV antibiotics. For the first 2 episodes of diverticular disease, usually it's just treated with antibiotics. It's kind of an old thought now that everybody will say, oh, I have to avoid nuts or avoid this or seeds and all this other thing, but that's really, the recommendations change. The current recommendations say that nuts and seeds don't really make a difference in diverticular disease, although some people will swear they will. So it's just something to keep an eye on. And if people believe that it makes their disease worse, just let them go with it. Anyway, should they have multiple episodes of diverticular disease, they may need to actually consider removal of that diseased part of the colon to prevent them further episodes of diverticular diseases. We're going to talk about some of the kinds of GI cancers now. Oral cancer is squamous cell of the tongue and the mouth floor. It's primarily influenced by tobacco and alcohol use, preceded by pre-malignant lesions. The manifestations often include a lump, thickening, soreness in the mouth, soreness of the tongue or the throat. Treatment includes surgery and radiation. Esophageal cancer can either be a squamous cell carcinoma or an adenocarcinoma. It usually presents itself as dysphagia and weight loss. Diagnosis is made by endoscopy and biopsy. People at most risk for esophageal cancer also usually have a high incidence of smoking. Treatment generally involves surgery, chemotherapy, and radiation. Gastric cancer is the adenocarcinoma is the most common type. It's strongly associated with salted, cured, pickled, preserved, and smoked foods. It can be asymptomatic in the early stages. It is often diagnosed with a biopsy, and treatment includes surgery to remove that area and is often curative. Liver cancer is commonly a secondary tumor that is metastasized. Clinical manifestations of that include anorexia, fever, jaundice, nausea and vomiting, abdominal pain, and hepatoglomegaly. Treatment includes chemotherapy, removal of part of the liver, and sometimes non-traditional cancer treatment protocols are instituted. Pancreatic cancer is an aggressive malignancy. It's a ductal adenocarcinoma arising from exocrine cells. It can spread quickly to nearby structures. People often present suddenly. People will say, oh, the symptoms are very mild in the beginning, like, oh, I've been tired or weak and, just haven't been feeling like myself. But how many times do we blow those symptoms off? And then they present when they really have upper abdominal pain, indigestion, they've lost weight. And the prognosis is dismal, as the PowerPoint says. When it says there's no effective treatment, people often try surgery or chemotherapy, but sometimes it just progresses so fast that there is nothing really that you can do for it. It's quite a horrible cancer to have. And colorectal cancer often develops from an adenomatosis polyp. It's associated with dietary factors. It's asymptomatic. And the most important thing we can do to check for this is be consistent with the routine colonoscopy screenings. If you are someone who has a family history of colorectal cancer, you will start your screenings typically at the age of 40. Everyone else will start their screenings at the age of 50. And then depending on what they find, you'll be told when your next treatment is, your next colonoscopy would be. Treatment includes a polypectomy during the colonoscopy, colon resection, where they remove the cancer part for cancers in stages 1 through 3. The important thing is giving people lifestyle changes and being consistent with their routine screenings. So I hope you've enjoyed this presentation on the gastrointestinal function. If you have any questions, just please let me know.